Hello, this is Helen Allett from LSTM. This lecture is about the management of shock and the unconscious patient. Our learning outcomes are to recognise shock, to differentiate hypovolemic shock from septic shock, to be able to manage a shocked patient using a structured approach, to recognise and grade reduced levels of consciousness, and to manage a patient with a reduced level of consciousness. What is shock? When a patient is in shock, it means that there is inadequate perfusion of the organs with oxygenated blood related to a reduced cardiovascular output. Shock is a life-threatening condition that requires immediate intensive treatment. If a patient with shock is not managed safely and rapidly, then they will die in a very short time. Types of shock. Shock is divided into 4 main types based upon the underlying causes, and it is helpful to understand this as we plan the management of shock. Firstly, hypovolemic shock. This relates to a decrease in the blood volume, and the pressure in the blood vessels is low because there is less blood flowing through them. With cardiogenic shock, there is a normal fluid volume, but the blood flow and the pressure is reduced due to a dysfunction of the ventricles or the pumping chambers of the heart. The heart is sick in itself and is therefore unable to pump the blood at an adequate pressure around the body. With obstructive shock, this is caused by a physical obstruction to the large blood vessels or the heart itself. And this could happen, for example, in a situation such as pulmonary embolism, where large vessels in the lungs are blocked by blood clots, or cardiac tamponade, which is a situation that usually happens following trauma, where blood collects in the pericardium around the heart, and therefore the heart is unable to expand and contract to its normal extent. And finally, distributive shock. The most common cause of this is septic shock, and it relates to abnormal distribution of blood flow in small vessels. So this may be because the small vessels are inappropriately dilated. So again, the volume is the same, but the size of the vessels, the capacity of the vessels has become larger because of inappropriate relaxation. And this means that the pressure then becomes lower. It's important to remember with septic shock that it's defined as shock that's happening despite intravenous fluid resuscitation. So that means you've tried to put in extra fluid to fill that extra space, but nevertheless, the blood pressure still remains so low that the patient is in shock. In pregnant women, there are 2 major causes. Bleeding, which is a factor for hypovolemic shock, and sepsis, which, as we've heard, is a form of distributive shock. There are other causes which can occur in pregnant women, but much less commonly. So what would we see in a patient who was suffering from shock? Shock will have an effect on every organ system. Firstly, the brain. So the patient may appear to be anxious or agitated, confused, drowsy or unconscious, as the circulation and the oxygenation to the brain is reduced, so the brain function is adversely affected. So never dismiss an agitated patient and think that they are being uncooperative. It might well be that they are going into shock. The skin may feel cold and clammy, and it often does in shock, particularly hypovolemic shock. But in the early stages of septic shock, the skin is likely to feel abnormally warm. Although as septic shock progresses and the blood supply to the skin is finally shut down, this may change. The conjunctivae will appear to be pale. With regard to the vital signs, the breathing rate will be rapid. This is due to a compensatory mechanism. As oxygen carrying capacity is challenged, a patient will tend to breathe more rapidly to try to get more oxygen into the body through the lungs. And so you will very often find that the respiratory rate is abnormally high in a shocked patient. And indeed, a rise in the respiratory rate is one of the most sensitive signs that we can notice. The pulse may feel weak, but that's a subjective finding. However, an objective finding would be a fast pulse going at a rate of more than 100 a minute. In septic shock, the pulse may feel bounding. So remember, rapid breathing and rapid pulse. And then as shock develops, the blood pressure will fall. But this is a late sign, and we often see a rise in respiratory rate and pulse quite a time before we see a low blood pressure. It's very important, therefore, to realise that low blood pressure in the context of rapid breathing and rapid pulse is extremely serious, because the blood pressure falls when the body has run out of compensatory mechanisms and can no longer maintain a circulation at a normal pressure. And this is very serious and requires immediate action. With regard to the kidneys, the urine output will reduce and we will see a poor urine output in shock. And as the uterus is affected and the blood supply is diverted from the uterus, the fetal heart rate may demonstrate signs of fetal distress, so be tachycardic or bradycardic, or even in some situations absent altogether, signifying an intrauterine fetal death. With septic shock, we will see a fast heart rate, fast breathing, low blood pressure, and changes in temperature. In the earlier stages of septic shock, there is likely to be a high temperature, but later on, then the temperature may be subnormal. And as I mentioned before, there is often a poor response to simple fluid resuscitation. So how do we act when we have a patient who appears to be in shock? Well, it's very difficult to manage such a serious condition on your own, so it's very important to shout for help if help is likely to be available. The patient should have a rapid assessment of the level of consciousness. If the patient is pregnant, then very rapidly put her into a left lateral tilt. This is a tilt to displace the uterus from the vena cava and to help with cardiac return. So you can either do this by putting a tilt, which is a pillow or a folded up blanket or some other thing under the patient's hip to tilt her towards the left. Or if you've got help available, you can do what's known as manual uterine displacement, where a helper places two hands on the uterus and pushes it towards the patient's left. If the patient is not breathing, then obviously open the airway, and if breathing is still not present, once the airway is properly opened, then you would need to commence cardiopulmonary resuscitation. However, if the patient is breathing, then we need to give oxygen. It is always appropriate to give oxygen in cases of maternal shock, and that should be given as high flow oxygen. If the patient is unconscious, then they will not have a gag reflex and they will be at risk of aspiration. So it's very important then to place them in the full recovery position, the full left lateral position. This is for a different reason than the left lateral tilt. As I've said, the left lateral tilt is to remove the pressure of the gravid uterus from the inferior vena cava and improve cardiac return and hence cardiac output. The full recovery position will of course do this, but more than that, it will protect the patient's airway from aspiration of any vomit. And remember that it's very important to avoid aspiration because vomit contains hydrochloric acid from the stomach, and this would be very corrosive to the lungs if inhaled. If the patient is unconscious for a prolonged period of time, you will have to turn them from one recovery position to the alternative side every 2 hours in order to avoid the development of pressure sores. So moving on to circulation, we need to assess and treat the circulation. So to treat, we will need to get intravenous access and take any appropriate blood samples before commencing fluid resuscitation. So if the pulse is rapid and the blood pressure is low, or there's heavy vaginal bleeding in particular, we need to give rapid intravenous fluids. So we can give 1 litre of fluids intravenously over 20 minutes and follow this up with a 2nd litre over a similar period of time, perhaps 30 minutes. But the exact number of minutes is not crucial. The key thing is to rapidly provide fluid resuscitation. And this is important in both hypovolemic and septic shock. After that, you need to review the situation and you may need to repeat. Although it's important to not give too much fluid, so I wouldn't want you to be giving more than 3 litres without some alternative management because there is a risk of causing pulmonary edema. Beware that if you suspect the patient has underlying very severe anemia or severe preeclampsia or a suspicion of cardiac failure as a primary cause of the shock, then fluid restriction would be appropriate, and giving large amounts of clear fluid would tend to make the situation worse. However, it should be quite easily apparent which of these problems, if any, are present. So, further care of shock. So it does depend on the cause of the shock, and if there is hemorrhage or septic shock, we will have to treat according to the cause, because if there's bleeding, we will need to stop it, as well as to think about fluid and blood replacement. If there is septic shock, then we will need to give broad spectrum antibiotics very soon if we suspect that sepsis is the root cause of the problem. The longer that you delay in giving broad spectrum antibiotics, the more likely it is that the shock will become irreversible and the patient will die. The woman should be covered and kept warm, and we should document carefully input and output of fluids, as well as any drugs given. And remember that I pointed out that if we are too over-enthusiastic with fluid replacement, we do run the risk of causing pulmonary edema. But nevertheless, we should not delay our first 2 litres of fluid. The mother and the baby should be continually monitored, and this does require intensive one-to-one care to be given if we are to save women who are in shock. A referral should always be made to a comprehensive emergency care facility, but you must stabilise the woman before the transfer, otherwise she may die during the transfer or rapidly upon arrival at the comprehensive facility. Just a quick rule of thumb about blood loss. So blood loss might be ongoing and signs can progressively worsen very quickly. But as a rule of thumb, if we have nothing other than a mild increase in pulse, it's possible that the blood loss could be up to 700 mils. And the action would be to replace with intravenous fluid, as well as to ensure that the blood loss is arrested. If you notice that there's an increase in pulse and respiratory rate, which is faster, then you may well have a blood loss of up to 1500 mils. And again, we would give intravenous fluids. Beyond that, we may notice a fall in blood pressure and a further increase in pulse and respiratory rate. And this patient will be in shock. And if so, then she will need to be given blood in addition to intravenous fluids. You can't really lose 2 litres without needing a blood transfusion. when the patient becomes cold and drowsy with a very rapid pulse and very low blood pressure, it's likely that they will have lost 2.5 litres or more, and a large blood transfusion will be required. If you have a patient who has pre-existing anemia, then all these signs are likely to develop earlier with less blood loss, and they will need more transfusion if their lives are to be saved. Turning to the unconscious patient, remember that a decrease in the level of consciousness is usually a sign of lack of oxygen to the brain, and lack of oxygen to the brain could result from either a reduced blood flow to the brain, as we might see with a severe hemorrhage, or a reduced blood oxygen content, or both. So, how can we rapidly assess the conscious level? It's often quite difficult to remember all the different score lines in the Glasgow Coma score, but this is a very quick and simple way to assess conscious level, which is adequate for most cases of obstetric care. So A means alert. Alert means that the patient has got their eyes open and they are looking around and they are immediately responding when you speak to them. V is a patient who does not have their eyes open but will open their eyes and respond to you when you speak to them. If a patient does not respond to voice, do they respond to pain? So we usually assess pain by rubbing the knuckles on the sternum. Please don't pinch the patient or use other means of eliciting pain. Just a sternal rub with the knuckles is usually quite adequate to see if the patient will respond to a painful stimulus. They may not respond by speaking to you, but they may move slightly and try to get away from the source of the pain. A patient who does not even respond to pain is classified as unresponsive, and this is the most serious level of loss of consciousness. So this simple and rapid scheme is known as AVPU: alert, responding to voice, responding only to pain, or unresponsive. So if you have a patient with a reduced level of consciousness, then something is seriously wrong. You need to get help. And first of all, as always, check the breathing, make sure the airway is open, and if not, open it. And if necessary, assist with breathing, but certainly give oxygen. If a patient has a reduced level of consciousness, it is always important to ensure an adequate supply of oxygen, so give them some high flow oxygen. Initially, place the patient in the recovery position, and as I mentioned before, remember to turn them 2 hourly. And we're doing this, as we will recall, to avoid aspiration of vomit into the lungs. We need to check the circulation, pulse, blood pressure and temperature, and to get intravenous access. And then assess how deeply unconscious the patient is. Do remember that unconscious patients are not necessarily paralysed and that they may move. So even if you place the patient in a safe position, it's important to watch them in case they move and roll back onto the flat of their back and become at risk of aspiration and venocaval compression. So patients who are unconscious should always be watched. Having done the primary survey of airway, breathing and circulation and assessment of conscious level, we then need to move on to a secondary survey and do a head-to-toe examination. We need to check for all possible causes of a lack of consciousness. It may well be that this is a patient in shock, but there are other causes in addition. So assess the patient's pupils to look for lateralizing signs. Do both pupils react to light equally? Or do they have fixed dilated pupils, for example? Check the blood sugar, because hypo and hyperglycemia can both affect the level of consciousness, and consider other possible causes. So, for example, eclampsia, where you might detect very high blood pressure and protein in the urine. The patient could have epilepsy and could be post-ictal. There may be diseases such as malaria or meningitis, which affect brain function and level of consciousness, or more generalized sepsis, including conditions such as pneumonia or severe hemorrhage, as in hypovolemic shock. So all these things may be factors that affect the level of consciousness. And in addition, you should always check the stage of the pregnancy if the patient is undelivered, and the fetal heart rate. We will be very happy to discuss any questions you may have in the live session later. So to recap, we've thought about recognition of shock, we've thought about the common causes, including bleeding and sepsis, and some of the less common causes as well. We've outlined the main principles of management and how to grade the level of consciousness and then to safely manage the basic care of a patient with a reduced level of consciousness. Thank you for listening.